We can start. We can start. Yes.
Yeah, fine. So, very good evening, everyone. On behalf of AstraZeneca, I am welcoming you all for this evening academic symposium. The topic for the day is a right strategy for carrying lungs better. To deliver this talk, today we have a very eminent and rich experienced doctor from Chennai. Of course, it's my privilege and honor to introduce Dr. Kailash to all of you. Dr. Kailash is an asthma consultant and chest specialist from Asthma Studio, Velachery, Chennai. No? Sir has been a teaching faculty at Madras Medical College and Kilpatrick Medical College for undergraduates and postgraduates for a long time. He has also obtained fellowships and membership from various reputed medical bodies. Has conducted numerous medical conferences, workshops, and seminars for general practitioners, physicians. He is currently a vice president for IMA Chennai Metro and secretary for Independent Medical Practitioners Association of India. He has worked as a medical superintendent for Chennai Meenakshi Hospital and Venkateshwara Hospital. His area of interest is to talking to the medical profession on chest topics, especially airway disorders. His rich experience is helped him in teaching, has helped him to organize a useful physical and mental health workshops and seminars for general public. Sir is also a regular faculty for institutions like banks, IT companies, schools, colleges on health-related topics. Sir is a very dynamic, versatile, and humorous trainer for personality development courses. Sir has given a lot of lectures in local, regional, and national level conferences. Today, he is with us to share his experience, especially to the right strategy for carrying lungs. With this, a very warm welcome to Dr. Kailash to deliver the talk. Over to you, sir.
Thanks, Nagaraj. Thank you very much. Anyway, lungs have really taken importance after COVID. After COVID, the importance of the importance of a pulmonologist has really gone up multifold. So many times, a lot of people know the value of pulmonology only after COVID. So we should thank COVID for that. But COVID also did one thing was, or a short period of time for about 2 years when COVID was there, we had very little cases because there was no pollution. Everybody was wearing masks. So even asthma, COPD, everything plunged down during the COVID time. But whatever said and done, the value, because COVID affected the lungs and all pulmonologists became very active. So we're going to talk today on this topic, like how management of asthma has evolved post-COVID era, how it has evolved, or what COVID can teach us in management of asthma, risk associated with SABA overusage. In fact, this is one thing which a lot of people are using, a lot of salbutamol inhalers. In fact, this was tremendous. SABA was used in such huge quantities about 10-15 years before. I remember everybody used to carry a SABA with them. SABA is nothing but routine inhaler which is used for giving instant release. Risk associated with SABA, we're going to tell you about it. Then a couple of studies and single maintenance and reliever therapy, how it can help. Then clinical studies supporting maintenance and reliever regimens. Device matters, how device is important for delivering the drug for an asthmatic. And of course, management of uncontrolled step 5 asthma patients. These are things we're going to discuss in the next half an hour. If you have any questions, please keep it. We can discuss about it at the end. Okay, the first thing is COVID-19 asthma. Actually, what COVID-19 has taught us is advise patients with asthma to continue taking their prescribed asthma medication, particularly in what we have learned. The lesson we have learned is during COVID time, a lot of people were scared to use inhaled corticosteroids. They thought it will increase COVID and all that. But what we have found out that asthma medication should be continued as usual during COVID time. Only then the chances of getting an acute attack of asthma was reduced. Stopping ICS often leads to potentially dangerous worsening of asthma. So after COVID, we came to a conclusion, yes, the most important thing is patients will have to take ICS, inhaled corticosteroids, irrespective of the disease, irrespective of COVID, you have to continue. Only then you will not fall prey to worsening of asthma. Then make sure that all patients have a written asthma action plan about instructions about increasing control and relief of medication when asthma was. This also is important. You have to tell the patient during COVID time, if you had these, increase the inhalers twice, thrice, and all that, so that you will not have a worsening of asthma. Then one thing which we learned from COVID was avoid nebulizers where possible. Nebulizers increase the risk of disseminating the virus to other patients and other healthcare professionals. So in my clinic and all, we never gave any inhalers during that time. We saw to it. We had to have a separate room where you could give an inhaler, or we exclusively designed a room where the patient alone will be there when the inhaler is there, and then we'll sterilize the entire room so that the virus does not get disseminated. So inhalers, nebulizers were reduced during COVID time, but pressurized meter dose inhaler via a spacer was preferred treatment during severe exacerbation. Whenever a patient had severe problem, instead of a nebulizer, we used to give many of you would have seen these uh, spacer where we could use the mask and then ask the patient to take it, because this really helped with a tight mask. We really used to give medication, steroid, ICS through the spacer. So these are the lessons which we learned during COVID time. Of course, our patients, okay. The answer is yes. Our patients really have to complications. Hold on 1 minute. I'm not able to get rid of this. Okay. We found out the incidence of asthma therapy really increased with uh, in COVID conditions. Was there worsening of asthma? The answer is yes. Those with chronic respiratory disease had a higher mortality. Any respiratory disease, just not only asthma, any respiratory COPD or all that, they were able to find. We found that the incidence of asthma worsening was there with this particular thing. Okay. Management of asthma in the COVID era, what exactly happened was, our people, Association of Asthma in relation to death with COPD, what we noticed was, our people with asthma at increased risk of COVID-19 or severe COVID-19? The answer was, people with asthma do not appear to have an increased risk of acquiring COVID-19. Vice versa, like if you had COVID, you have to treat asthma properly. But if a person had asthma, then he had a increased risk of acquiring COVID-19, and hence increased risk of severe COVID-19 also. But with well-controlled asthma, the chance was much less. Then of course, our people with asthma at increased risk of COVID-19 related death. Overall, people with well-controlled asthma were not at an increased death of rate. That if your asthma is well under control, then of course you do not have an increased death of COVID. COVID-related death were not noticed if a person had his asthma under control. But if his asthma or respiratory infection was not under control, the chance of getting COVID-19 death was quite high. However, the risk of COVID-19 death was increased in people who had recently needed oral corticosteroids, OCS we call it, for asthma. So if you had used, instead of inhaled corticosteroid, if you had used oral corticosteroids, and in hospital patients severe asthma, then the chances of risk of COVID death was quite high. What are the implications of asthma management? It is important to continue good asthma management as prescribed by GINA guidelines, with strategies to maintain good asthma control. Good control reduce the risk of severe exacerbation and minimize the need for OCS. The crux of the problem was to avoid OCS. That is what is important. Now, if you use your inhaled corticosteroids properly, the need for an oral corticosteroids was not there. If you use oral corticosteroids, then the chances of COVID death was increased. So normally in general practice, what happens is we have a tendency to use oral steroids. If you use steroids, then the chances of COVID affecting your you getting hospitalized or morbidity was quite high. Mortality also was high if you use oral steroids. Has there been more asthma exacerbation during the pandemic? No. In fact, I told you in 2020, many countries saw a reduction in asthma exacerbation and influenza-related illness. The reasons are this, not precise, no, but probably we think hand washing, masking, and social physical distancing that reduce the incidence of other respiratory infections like influenza, everything. So we found the incidence of asthma was much less during then. Why
Good for you.
we want to experiment with SABA? This is the most important thing because lot of patients use SABA on their own. They get relief with SABA. SABA is short-acting beta agonist like a salbutamol, which is commonly used. So that instrument should not be, that device, medication should not be used frequently. Why? Why it should not be used? Because it is found that if you use even 3 canisters of SABA, this salbutamol, it increase in the course of a year, it increases increased risk of severe exacerbation was found. A study had found out that it increased the severe exacerbation. But if you use 12, I've seen people every month they'll buy one SABA as an inhaler for a symptom relief, and they found increased risk of asthma-related death if you use too much. That is why we want to regular use of SABA, increase allergic responses and airway inflammation, because SABA did not address the inflammation or the allergic response in the respiratory tract. It only gave temporary relief. It gave a bronchodilation to the respiratory tract, bronchioles. That's all. Nothing else it gave. That is why please do not advocate SABA separately in any of your prescriptions with because of this particular thing. The more he uses SABA, more he uses these inhalers, salbutamol inhalers, chances of asthma-related deaths are quite common. So how do we reduce the risk of complication asthma, especially in the COVID era, was reduce the risk of being infected. Social distancing really helped. Of course, now all that is gone. Wearing a face mask in an enclosed environment also is there. If you go to all malls, nobody's wearing mask and things like that. Maintain a good hand hygiene. This is what is very important, because we used to, during COVID time, we used to wash our hands the moment you get into the house. All that is slowly going away. But if you had followed all this, the chance of getting infected with COVID is any asthma related problem is much. Ensure that asthma is well controlled by the latest GINA guidelines for asthma, which I'm going to tell you shortly. Why this track 1 is preferred is because low dose ICS formoterol as a reliever reduces the risk of severe exacerbation compared with regimens with SABA as a reliever, which is in the second track. So please remember, the reliever, in any asthma therapy, you have two types. One is a controller, another is a reliever. Controller is that which controls the problem, that which cures the problem, that is ICS. But ICS alone, it will take a long time for the symptom relief. So you need a reliever. Formoterol is a reliever in this combination, ICS formoterol. But in the other study where they use ICS separately and SABA separately, then the controller was ICS, but the reliever was salbutamol, which is not good. But here in this study, where ICS formoterol was used together, they had very little. It reduces severe exacerbation compared to the regimens with SABA. How it is used? When a patient at any treatment step had asthma symptom, they use low dose ICS formoterol in a single inhaler for symptom relief. Whereas there they used to have separately. But what happens is when you take an ICS, you don't get relief immediately. But when you take a SABA, it gives immediate relief. So you continue to use a lot of SABA. That is why they say in track 1, which is the preferred, use this combination rather than using SABA separately. If you use the second trap, normally previously they used to take SABA separately and IC separately. That was the one which gave a lot of point. This combination, a lot of people had problem. Before considering a regimen with SABA reliever, consider whether the patient is likely to be adherent daily. What happens is once you use a SABA, he gets relief and he does not take the controller properly. What happens is whatever our patients are so tuned to, the moment he gets relief, and it's very idea, I don't need ICS, because ICS is not going to give him immediate relief. So he will avoid ICS. That is why adherence to controller will go away if you use SABA separately. If they are poorly adherent, they will get a higher. Why I'm trying to stress this SABA is because a lot of people in general practice are used to this type of relief, giving SAPA separately and giving ICS separately. So please do not, all that combination of giving separately is gone now. It's all combination of formoterol with the ICS or salmeterol with ICS, but formoterol ICS is a better combination. Okay. Bronchial asthma by definition is nothing but, the most important word is airway hypersensitivity and airway inflammation. This is the most important word. For this sake only we use ICS. Inhaled corticosteroid is used only for this particular statement. Of course, for airway obstruction, we need formoterol or salmeterol or salbutamol. All these things are used only for airway obstruction. But a combination of these two will give immediate relief. Combination of this. So you decide which is the best. I'll tell you now what is the best combination for this. Of course, these are the only two medications that are available for controlling asthma. Right? It controls the symptoms. It prevents the cause of the problem. Such a exacerbation, all that. Reliever, only during worsening asthma and exacerbation, it gives relief. It just temporarily bronchodilates the entire thing. So now the latest concept is never use separately single maintenance reliever M&R therapy. That is what is the latest thing which I'm going to tell you. Clinical studies show significant reduction exacerbation with maintenance and reliever together. There are a lot of studies with the budesonide and formoterol. In 2004, we had a STEP study. 2005, we have STAY and Cosmos. 2016, lot of studies have come all across to prove that these patients with a combination of budesonide and formoterol had very little exacerbations of asthma when compared to any other combination. Now, this is a study which says they use salbutamol and fluticasone. All abroad in India, we have a lot of combinations. But abroad, the only combination they have is either salbutamol fluticasone or formoterol budesonide. These are the only two combinations that is available abroad. Now, when they use salmeterol and fluticasone at 500
Hello, sir. We lost your voice. Hello, Mani.
What happened? This share screening is gone.
Yes, sir. We lost your voice for almost for last 10 to 15 seconds, sir.
Oh. Okay.
Please share this slide, sir.
Okay.
The slide which you started talking about salmeterol, fluticasone, and formoterol.
Okay. I'll go back.
You showed both the devices, sir. From there, we lost you.
Okay. I'll go back. Okay. See, the salmeterol
please share your screen, sir.
Are you able to hear me? Are you able to hear me now?
Very much audible, sir. We are not able to see the screen, sir. Please share your screen.
Oh, why the screen is not seen? I don't know. Are you able to see me now?
No, sir. Share screen, sir.
Why? What is the problem for?
Now it is visible, sir. Now it is visible. Yeah.
Where did you hear me from? Where? This is okay. This is okay from here.
No. Next slide, sir. Next slide. No. Before what? This
one.
Yeah.
From this. Okay. This slide shows that we budesonide formoterol as an anti-inflammatory reliever plus maintenance program. There are a lot of studies to show that this is the best form of therapy for controlling asthma. This is the best one. Next, of course, there's a meta-analysis. One inhaler regimen reduced the risk of exacerbation. They found out that a lot of combinations were found, but this particular combination of formoterol and budesonide had the least risk of exacerbation. That is why this is preferred therapy all over the world. In a single maintenance reliever therapy, there are very...
Sorry to interrupt, sir. Please make it your slide a big one, sir.
Full screen,
sir. Yes, sir.
Are you able to see now full screen?
Now it is fine. Sir.
Okay. So salmeterol, fluticasone, and formoterol budesonide are the only two combinations that are available all over the world. all over the world currently. Of course, now other drugs have come like Belantrol and all that, but still major portion in the world is only salmeterol, fluticasone, and formoterol. The dosage in salmeterol, fluticasone is higher when compared to, it's 25% lower dose when compared to salmeterol, fluticasone. That is why it is preferred. Second, they found out the number of exacerbations were much more with salmeterol, fluticasone 138 when compared to formoterol, which is only 94, which shows that there is a 33% reduction in exacerbation. Then for ER visits or hospitalization, when you use the first combination, 70 patients got admitted to hospital in a huge study where 48 patients got only admitted, which means there is a 31% hospitalization reduction, which is also good for this combination. And oral corticoid usage came up in these, some of these patients. About 148 courses were administered with this course, with this particular salmeterol, fluticasone, whereas only 88 courses were administered with formoterol, fluticasone. That is, there is a 58% reduction of oral corticosteroid therapy. So that is why they say formoterol budesonide is much better when compared to salmeterol, fluticasone. Okay. So in conclusion, that they say budesonide, formoterol, anti-inflammatory reliever plus maintenance therapy has been extensively studied. Almost 16,500 patients with a moderate to severe asthma across. There are 7 trials which I told you. Reduce severe exacerbation in every study against all comparators. That is the biggest advantage. All over the world, the study showed this. That is why this particular drug is very popular all over the globe. Improved also showed that it improved asthma symptoms, lung function, and reliever use in comparison to all budesonide regimens across studies. Okay, now we'll go to a little bit of how to give track 1 based regimen through appropriate device. Now, track 1, which I told you, Gina, was to give formoterol, budesonide, that is a reliever and a zinc together. So how to give it? What is the device? There are a lot of devices. In fact, the number of late, I think from 1990 onwards, these are the only 2 drugs I have seen for in my practice of asthma, 1990-95 onwards. There are not much of new drugs have come into asthma, but only the devices have improved. Devices have, at least I would have seen 65 different devices in my 40 years of experience. But all these devices also have to be careful because you cannot use any device like that. How does what are the factors that influence the drug delivery from a device are? One is the patient factor, another one is device factor, another one is the formulation factor. Patient factor, age, very important. According to the age of the patient only, you should decide upon the device. What device to give is only the age of the patient. Socio-economic condition in India, this is very important. You cannot give very expensive medicines in India because people won't buy. So according to socio-economic status, you give. I always, whenever I have a patient, at the moment I write down the prescription, I find out what is his occupation, his income. Then only I'll decide how to give. Because if I give a very costly drug, he may not take it. So that is a problem. Second is according to the disease condition. Like for example, it was mild asthma, moderate asthma, severe COPD. So decide the device according to that. And personal acceptance. Patient also has to accept the device. So what I do is I show the devices, tell them these are the various devices. Which do you think is perfect? This is how you have to do a device. If a patient will say, I'm very happy with this device. Then if he accepts it, then the adherence for the device will be much better. Then of course, we give training. Of course, I have asthma counselor in the clinic, we give training. But if you have the time, you must train the patient pakka to take the device. Device factor, what are the factors that influences are? Efficient delivery to the site of action. The site of action has to be in the bronchiole. It should not go to the alveolus. It should not be in the trachea. It has to be in the bronchiole. So find out whether the device can deliver the drug to the bronchiole. The design of the device, how it is designed so that it can effectively deliver the drug. Whether it's able to give consistent doses with each inhalation. Ease of use, whether the patient is able to use it very easily. And of course, the cost. All these are the factors when it comes to device. When it comes to formulation, stability and safety, we have to find out whether formoterol, budesonide is a very stable combination and whether it's safe. So we have found out salmeterol and budesonide as a very safe and stable formulation which can used from various. But what are the devices that are available? In fact, there are a lot of devices I told you. Reasons for poor control in asthma. There's a study which said that misuse of pressurized meter dose, which is a normal thing. We've always seen this inhaler, isn't it? The routine inhaler which people use, the device, the pressurized meter dose inhaler is indirectly linked to decrease asthma stability because the patient is not able to do hand-mouth coordination. The biggest problem is patient is not able to do hand-mouth coordination. That is why pressurized MDI, we call it. MDI is not very useful, not a very useful to use it directly. Poor inhalation technique is a common problem among patients with asthma. This is the big problem. All of the diseases, we give tablets, oral medications, and all that, injections. But in asthma, we have almost discontinued oral medications, only inhaler therapy. So how you do the technique is more important than even, and what medication you use is very, very important. Trainer should be competent and inhaler technique should be rechecked often. In our clinic, we recheck every time he comes. He has to bring the inhaler. The asthma counselor will check whether he is doing it properly. The choice of inhaler for ICS delivery is more important because of the greater need to specifically accurately target. Because ICS is the only drug, that is inhaled corticosteroid, is the only drug which cures the problem, The other one only gives relief. So very, very important is how ICS is to be delivered for asthmatic people is very important. Next, of course, turbohaler is one device. This is a turbohaler, which many of you would have seen. So the meter dose inhaler is a routine one, which many of you would have. I don't have a meter dose inhaler, which is commonly used in practice. The dry powder inhalers, many of you would have seen the routine ones, like all these things which you have seen. And this is turbohaler. This is also a dry powder inhaler. But the advantage with each is, even in a meter dose inhaler, directly if you use, only 21% of the drug is deposited in the lungs. With the dry powder, is half that amount, only 14%. Whereas with the turbohaler, the amount of drug deposit is almost 38%, which is fantastic. In fact, it's almost 50% of the drug. Now, even if you have 30% deposit in the lung, you'll get tremendous relief. That is what is important. So turbohaler is able to give you about 38% deposition in the lung, which is fantastic, which is really good. So turbohaler is one device for all age groups and severities, because even a child of 5 years can use this drug. An elderly person with very low inspiratory capacity also can use it. In very severe COPD also, we have found that turbohaler is able, because the amount of inspiratory flow that is required is only 30 liters per minute, which is very minimal. To be able to do like this is more than enough. That is why in even severe COPD, you're able to, children with asthma, patients with acute asthma also will have almost 30 liters per minute. Patients with normal asthma, of course, they'll have normal. So that is the advantage of an instrument. The instrument should be able to deliver at a very low inspiratory flow rate. That is very important. And this is one device which can really do that job. All of the devices, we are finding it difficult, but this is a device which can do that. Of course, what optimal device should look like is, one is ease of use to eliminate potential incorrect use. That is, if the device is so designed that it is easily, you can easily operate it, that is fine. Effective delivery of drug, even if patient's technique or coordination, even if it's slightly poor, the drug should be able to go into, even if the patient is not able to do it slightly incorrectly, also the drug should get into the system. High levels of drug deposition only in the lung to provide active drug to required doses and minimize systemic risk. Because if it goes to the alveoli, then the systemic absorption will be there. It has to be in the bronchial tree only. Uniform and consistent deposition of the drug and delivery of an accurate amount of drug repeatedly and consistently, that is what it means is, every time you press the instrument, a uniform and consistent quantity of drug should be delivered. That is what happens. And the size of particles also should be around 2 microns, should be about 2 microns, which is very good in this particular instrument. So 2 microns is the one which will get deposited in the, if it is less than 2 microns, then it goes to the alveolus. If it is more, then it will go and deposit in the trachea. Then the last one is option to administer multiple doses in succession without the need to reload the device. Normally in dry powder inhaler, you have to keep on putting the capsules. The patient will touch the capsule may become wet, moist and all that. But here, the entire drug is loaded at the base. It's all loaded in the base. So it comes out with every inhalation. Once you load, the instrument also is very simple. All you have to do is, the methodology is simple. There is a counter here to tell you how many doses are there. All you have to do is one right click and one left click. When you do the left click, you'll get a sound. You'll get a sound like this. I hope you're able to hear it. There is a sound. Once you get the sound, that means the medicine is loaded. All you have to do is keep in your mouth and suck. Suck as deep as possible into the lungs. Hold the medication. That is very important because the drug has to be in the bronchial tree for some time for its action to take place. Hold as much as possible. Then you can blow out the device. The advantage with this particular medication is you will never feel the particles being deposited in your pharynx. That is the biggest advantage and disadvantage also. The advantage is patients say, I never felt any most of the people with inhaler therapy, they complain of sore throat, they complain of a thrush in the throat and all that because of the ICS, because of the steroid. Whereas with this particular thing, the device is so beautifully, it pushes the drug directly into the trachea and to the bronchial tree so well that very little deposit occurs in the pharynx. In fact, the patient will never feel the drug also. So good that he has the desired effect without any side effects. The only side effect with inhaler is sore throat and thrush, which never occurs with this particular unit. So I think I have given you an insight onto this particular thing, how this particular device, this particular combination of drugs gives relief in asthma, and why this is the preferred thing, and what are the studies which support this. So with this, I think we will open the forum for discussion if there's anything.
Thank you so much for this wonderful talk, sir. Very nicely elucidated all the important points. With this, I request the delegates, if you have any question, you can unmute and you can ask to Dr. Kailash. You can even stay with your last slide, sir.
Okay. I mean, like, I want to see people. I have not seen them.
Okay.
Okay. Muttam Paramal is there. Rahul, you have any doubts about this? Yeah, there's one doctor, okay, Tara has said, how good is formoterol fluticasone combination? Yeah, there are some combination like formoterol fluticasone. The disadvantage with formoterol fluticasone is formoterol is a short-acting drug and fluticasone is a long-acting drug. You are combining two wrong. Formoterol and budesonide are the ideal combination. They act for 12 hours, which is excellent. You should always combine drug which has the same drug, the amount of time it works. Whereas salmeterol and fluticasone works for almost 18 hours. So they can be combined. So ideally, I would prefer you to combine formoterol with budesonide. This is a better combination. That's what Tara asked me. Yes, anything else? Rahul, what's the doubt? Yes, the moment you get the unit, you check there is a dosage. It should show 60. Normally, a turbo has 60 doses. So every time you do one, it reduces, but it doesn't reduce by one. Like it doesn't come to 59, 58 like that. After every 10 or 20 counts, it comes down like 60, 40, 20, and 0. So you can have a watch on it. It will slowly reduce. So numbering is important. Please do not keep on doing like this. Then it will go off. So the only one puff at a time you do. That's all. 60 doses were on. 60. If you are normally in well-controlled asthma, we use one dose at bedtime, which comes for 60 days. But in early cases, you'll have to use twice, morning one, night one, which will come for about 30 days. One unit will come for 1 month. Normally, Rotacapsule 1 month or most of this thing. Adhe marda. This is one puff morning and night.
I have another question to ask.
Yes, Tara, tell me.
You mentioned about budesonide and
formoterol
and
salmeterol and fluticasone.
Yes. So, which is the one that is sufficient for once a day dosage?
Once a day, of course. Once a day, if you want to give only once a day, then you go for salmeterol fluticasone. But if if the patient has control, total control, it is safer to use budesonide with formoterol. See, what I do is I start with formoterol budesonide twice a day till the patient settles down. Normally, what I do is I assess the patient's improvement first with the symptom. How his symptom is, how he's able to. Then, of course, I do a
Prakash.
Then we use peak flow meter to assess his condition. Then we also use nitric oxide, pheno, which is called the amount of exhaled nitric oxide in the respiratory tract, also gives us the amount of the inflammation that is going on in this respiratory tract. So once we use these parameters, if it is much better, then I go for once daily also of turbohaler, which is very effective.
So of the two, fluticasone and budesonide, which is the longer acting one?
No, fluticasone is longer acting than budesonide. Certainly, I fully agree with you. Fluticasone is a longer acting drug. But the disadvantage of fluticasone is little systemic absorption may be there, if there is there, because the more longer it stays in your system, the chances are you can have systemic absorption. So normally we prefer a short acting drug which has less side effects.
Okay. Right. Thank you.
Thank you. Thank you. Mike wanted to say something, is it?
No, it was just
okay. So what are the instructions to be advised to the user after each? Very, very important is after every usage of any inhaler, please remember to gargle your mouth once with just hot water, warm water, just gargle your mouth. That is more than important. Though more than enough for any inhaler you have to do. All the same thing holds good also for a turbohaler. But the chances turbohaler is very, very minimal option. I've asked many people, the turbohaler does not cause any irritation, but still I advise them to use at least drink the water, drink a cup of water after sing. The whole thing gets, once it goes into the digestive tract, it gets absorbed and goes away. Nothing gets. So you don't have to worry. I always tell them gargle and then drink a little water. That is only advice you have to give to all people who use any inhaler. Janaki Rajagopalan, you must be having some doubts, Janaki.
I think Dr. Rahul sir has asked about the recorded version. In fact, we are not discussed with Dr. Kailash, so we have not recorded this one. Probably in the subsequent session, we will take the concern from Dr. Kailash and we can record it.
Okay. Rahul, we should have done it. We forgot. Yeah, I yeah. Any other questions in the chat box? Anything else there?
I think whatever the questions in the chat box which you already addressed, you have been asked and you have been addressed.
Somebody
if there are any more question, I think I request delegates you can unmute and straight away you can ask for Dr. Kailash.
Am I audible, sir?
Sangeeta, yeah. Tell me, you're audible. Tell me, Sangeeta.
I want to know what are the common faulty techniques they do and how do we correct them?
For what? For
using the inhaler.
See, the faulty technique comes because first one is because the person who teaches him, if he is not good, then the problem will come. Like the commonest 80% of all people all over the world use only a meter dosage. This is the one which is used all over the world extensively. But the biggest problem with this particular device is hand-mouth coordination. The moment you keep it in your mouth, first you have to exhale fully and keep it in your mouth and suck. The moment it presses, you have to suck. But invariably, it's not possible. I've seen a lot of people in the best of the best people, they're not able to do the hand-mouth coordination. Pressing and inhalation together, they're not able to do. That is a big problem we face. So that is why this became, this drug did not deliver the enough ideal quantity of drug. That is why turbohaler has got a disadvantage. Biggest advantage is only when you suck, the medicine comes out. You don't have to worry about the hand-mouth coordination. The moment you suck, medicine comes in. So that is the advantage of this particular device. Even the dry powder, all dry powder inhalers also have the same. But the problem with the routine dry powder inhalers, lot of drugs get deposited about more 10 or 20% extra gets deposited on the throat and causes the moment patient has side effects, he doesn't take the adherence to the drug goes.
What is the cost of the turbo halo as compared to the rotahela?
Yeah. See, this is about 500 rupees for 1 month. If you buy, for example,
500 with the medicine, is it?
With the medicine, yes. The device and the medicine together, 500 maximum. Even a higher dose will be about 600 rupees, I think.
Hello.
Am I correct, Nagaraja? About 600 rupees, less than 600 rupees?
Yes, sir. 600 rupees.
Yeah, with the drug and the device together. Whereas if you buy a dry powder, it is about 300 rupees or 200 rupees, 300 device. And the medicine is about 400 rupees. 30 capsules is 400 rupees. So the cost wise, everything becomes same. Only thing is the drug delivery is very easy, and with the turbohaler, and the side effects are much less. So I have the only thing is here you have to throw away the device, whereas there device can be kept and you have to refill with capsules. That is the only thing. In fact, dry powder inhalers became popular in India only because Indians don't want to throw away anything. They want to keep everything at home.
So there is
Any
a
other
question
questions?
from in the chat box, sir. Dr. Abdullah. What is the question? Is it possible to get any kind of disease from that inhaler, or is it 100% safe for using? That is the first one. And he is also I got a bad cancer, and I want to be totally sure that it doesn't affect me in any bad ways. So your comment, sir.
Oh my God, I'm surprised that inhalers got bad cancer. What are the diseases that inhaler disease? See, if you're using inhaler for yourself, it's very unlikely that you get an infection from another person, because the inhalers are individualized by individual people. And it is 100% safe to use the drug, particularly formoterol budesonide, on a long-term use. But of course, patients will themselves slowly reduce the number of, even there are people, when if I ask them to do twice, if they get relief, they'll take only once and be done with it. But doesn't matter, but it's 100% safe. You don't have to worry, because in an inhaler, the amount of medicine that is given is in microgram. What is a microgram? 1 microgram is 1/1000th of a milligram. If you take an Astalin tablet, it's 4 milligram, which is 4000 micrograms. Whereas an inhaler contains about 100 micrograms. That's all. So that is the advantage of our inhaler over other. So there's very, very less chance of any disease. I got bad cancer. I totally want to be sure. No, cancer because of inhaler or because of anything else. If you have a cancer elsewhere in the body, this inhaler is not going to. You're not going to worry about this. If you have a cancer of the bladder, then you can take an inhaler. Nothing will happen for your wheeze. I hope I have answered Abura.
Thank you.
Yeah.
Yeah. Yes. Nebulization is not given as a routine. Please understand, do not give nebulization as a routine. It is, I tell them nebulization is a Brahmastra, it's the last resort. Don't keep on giving nebulization. Lot of Indian doctors prescribe nebulization as a first resort. Please do not use it, nebulization. Okay. So please, for heaven's sake, start nebulizer when